Todd Park used the phrase increasingly awesome. I don't think there's anybody who's as increasingly awesome as Todd Park, except perhaps those who are with us on our next panel to discuss industry innovators harnessing the power of health information technology. They represent an array of institutions that have really taken up the challenge of marrying the most advanced EHRs and other systems to improving the delivery of health care and really producing what Todd talked about, which is, in effect, better health care, lower cost by maximizing the power of health information. Let me introduce the three of them now, and they will speak in sequence. We're going to hear first from Jack Cochran, who is the Executive Director of the Permanente Federation, the national umbrella organization for the regional Permanente medical groups, which of course are the physician component of Kaiser Permanente. The groups employ more than 15,000 physicians, caring for 8.6 million Kaiser Permanente members. Before his appointment to the Permanente Federation in 2007, Dr. Cochran served as Executive Medical Director, President, and Chairman of the Board of the Colorado Permanente Medical Group. He began his career with the Colorado Group in 1990 as the Chief of Plastic Surgery and founder of the Plastic Surgery Department. He's a frequent speaker and author on a broad range of healthcare topics, including health information systems, and has participated in implementing many of the priorities called for in health reform, including Kaiser Permanente's electronic health record. He earned his medical degree from the University of Colorado and served residencies at Stanford and the University of Wisconsin, and is board certified in otolaryngology and in plastic and reconstructive surgery. We're going to hear after Jack speaks from Rebecca Armato, who's the Executive Director of Physician and Interoperability Services at Huntington Memorial Hospital in Pasadena, California. She's also a commissioner for the Certification Commission of Health Information Technology. She's responsible at Huntington for strategy, direction, and leadership for physician and interoperability initiatives, and also for Huntington Health eConnect, which is an advanced secure health information superhighway connecting the hospital-based and office-based care environments, Huntington RX, and other services designed to improve operations. She's also responsible for developing programs, seminars, and informational materials to assist physicians in qualifying for the federal incentives that are available for e-prescribing, for PQRI, for the EHR meaningful use incentives, and so on. She was appointed in January as a commissioner on CCHIT, and for the 2 years prior to that, she was a member of the Interoperability Working Group. She's a member of HIMSS and the Medical Group Management Association and has more than 30 years of healthcare and medical practice leadership experience working with physicians and hospitals. And to wrap up this morning, we'll hear from, or at least for this session, I should say, we'll hear from Paul Tang, who's the Chief Medical Information Officer of Palo Alto Medical Foundation and also the Vice Chair of the Department of Health and Human Services Health IT Policy Committee. He's a board-certified internist and Vice President, as I say, and CMIO at the Palo Alto, and is also Consulting Associate Professor of Medicine at Stanford University. Currently, over 50% of Palo Alto Medical Foundation's adult primary care patients are using PAMF online. PAMF has been using an electronic health record system since 1999, as well as now the personal health record system of PAMF online. Dr. Tang is the immediate past chair of the board of the American Medical Informatics Association and a member of the board of the National eHealth Collaborative and chair of the Value Case Steering Committee. He's an elected member of the Institute of Medicine and serves on its Healthcare Services Board. He also chaired an IOM Patient Safety Committee whose reports were published in 2003 and 2004, Patient Safety, a New Standard for Care and Key Capabilities of an Electronic Health Record System. Finally, he also chairs the National Quality Forum's Health Information Technology Expert Panel and is a member of the NQF Consensus Standards Panel Approval Committee and co-chairs the Measurement Implementation Strategy Work Group of the Quality Alliance Steering Committee. So as you have heard, all of these folks bring an extraordinary array of experience and expertise both within their organizations and with respect to the national organizations now that are working in so many ways to push forward the health information technology and quality improvement agendas. So we're going to start first, as I mentioned, with Dr. Cochran. So Jack, take it away.
Well, good morning. Great to be here. And I think what I'd just like to take a few minutes is to try to share, I think we're all on a fairly common journey of trying to get from the industrial age of medicine into the information age and to use information and patients at the center to try to become more effective in our care delivery to keep health care affordable and accessible to all people in this country. So I think I'm going to share some of the Kaiser points along that journey that have been learning points for us. Just a very brief introduction, because I know that when I went to California and I learned how West Coast-centric Kaiser Permanente is itself, just to show you who we are, where we are. We're fairly large. We're distributed all over, but we're not a nationally all-state present. 8.7 million members, 15,000 physicians, $44 billion company, et cetera. Largely integrated. Most states we have medical groups, we have office buildings, we have clinics, we have primary specialty care, and we have hospitals. But in 4 regions, we partner with community hospitals for our care. And I'll start with a reminder of healthcare IT. Old organization plus new technology equals costly old organization. And it's simply a reminder that we don't give new surgeons new robots and new instruments and new lasers to work and expect them to understand how to use them. We ask them to get training and to understand it. And as all those of you who know, who have a few scrapes and scars from putting in an IT system, there is not an owner's manual that says once it's in, this is how you use it to transform healthcare. It's about all of us embracing some of Todd's philosophy of openness to learning, to create this coalition of people who understand from each other how to learn how healthcare can get done well. I'm often reminded by Judy Faulkner from Epic Systems that on day one when we put in her system, it did 2 things. It added to our cost and it slowed down our doctors. And she asked me to stop saying that in public, so I'm going to stop saying that in public after today. But what it does is it enables us to be able to take information, technology, protocols, support tools, registries, et cetera, and then teams and team-based care to ask different questions in healthcare. So information technology, what we have a fully integrated electronic health record called Kaiser Permanente Health Connect. It's the Epic Systems product, which has been customized a bit for our use, targeted focus on prevention and chronic disease management. We also use it for ongoing performance and outcomes measurements. As my co-panelists will tell you, you have to have that culture of the clinicians who embrace measurement, who embrace comparison, and who embrace performance improvement therein for continuous improvement accountability, and what we call our patient portal, which is patient engagement through My Health Manager. This is a slide not intended to delve into, but just to sort of make sense for what we all struggle with. There's massive amounts of data that go into health IT systems, and it's for all kinds of uses. We have to then begin to sort and structure that data so that it becomes more useful information, a smaller set of information. And then we really take it through registries, through protocols, et cetera, to try to create knowledge and then to individualize and customize it for the individual patient to create great clinical utility. It's not just a big box full of random information. It's about how we use it. And so what are the kinds of tools that we go? We've been structurally integrated for 65 years. We've gotten good in the last few years because we've gotten more clinically integrated and we've gotten better at managing information and doing performance improvement. So we use disease registries, pathways of care, demand management, patient goals and prevention, and population care management all the time in managing populations and individuals. And I just show one example in finishing. This is a secondary prevention for cardiac care, patients who had myocardial events. I break down the categories in templates and information, technology and tools, and teams to get outcomes. The templates and information, we use clinical data, we embed guidelines and evidence-based medicine in there to develop protocols to improve outcomes. We have rehab programs and medication management, and we'll talk about how those get linked to patients. We use prompts and reports to support protocols through accessibility to all members of the care team. The technology and tools we use the electronic medical record and computer disease registry, and the teams we use, physicians, nurse managers, clinical pharmacists. At one point in time in the industrial age, this was all managed in the head and the office of a cardiologist. In the new world, it has to be managed in other ways by healthcare teams enabled by good information, technology, and support by good tools. And the results have been peer-reviewed, 88% reduction in cardiac-related mortality versus historical comparisons. It's peer-reviewed. You can look at it. And this is my final. I think that what we have done, I said we had gone from the industrial age to the information age. We've gone from a good integrated system to a really excellent clinically and information integrated system. And this is this year's NCQA results from Medicare. As you can see, Kaiser Permanente is making some good strides in the clinical quality space. So, long journey. We've enjoyed it. We've got an awful lot to learn. Thank you.
Good morning, and I guess we're all kind of from the West Coast, so we were all talking about trying to keep up with the morning here, but I'm humbled to be one at the head with these illustrious co-panel speakers because they've done so much. And we're just sitting out there in little old Pasadena. And while we are large, we're single, and we're old, we are the original little old lady of Pasadena, and inside of our garage is a little red Chevy that we drive very fast and very hard, and we're proud of what we're trying to do to help these small physician offices. We have over 1,000 physicians on our medical staff and 3,000 in the community whose patients come through our doors. And yet in the end, we are only a facility that has a license to house patients. It's the physicians in our community and the private physicians that have the license to treat them. And it's only together that we can actually provide care to everybody in our community. And if those of you that are familiar with the Rose Bowl, and we get a large influx, and by the way, if anybody wants a site visit while they're there, you have to book now because a lot of people use us as the excuse to come out during the Rose Bowl game in January, especially from the East Coast. So, but our physicians, along with our physicians, we treat and see and heal 11,000 patients a day, only 1,000 of those inside the walls of our institution and 10,000 inside of the community physician offices. And so if we're really committed, as we are, to helping improve the cost and quality of care in the community, we had to reach out and start to engage physicians in the community in that effort because they see as many patients in 10 days as we see an entire year. And while, as you heard, technology already makes the office-based and hospital-based information interchangeable, the art is making it personal and making it usable in that effort. And that's really where the real work begins when you talk about even 1 million mouse clicks a day. So we looked at the community and what we were facing a couple years ago when we were trying to figure out our path, and we knew that we had a higher than national average adoption of EMRs because they had the money to buy them, but they didn't have the money to use them. And so we sit there, and when I speak to our physicians in the community in a meeting like this and ask how many have an EMR, they're all proud to throw their hands up, and then I say how many are paperless, and I very rarely see a hand in the air on that one. And there are a lot of physicians, about 10% of those 3,000, that are within 5 to 7 years in retirement. They provide an extremely valuable service to an extremely needy group of patients, but yet they're feeling that they've got to retire fan. And so we need them to continue to practice medicine in our marketplace. And they're very clear about what they need: private, practice viability, reducing costs, controlling what data flows into their EMR. They're still very personal. They still have an opinion about their data versus other people's data and the trust in that information. It's got to be quick and easy to use in their thought flow and on a device of choice. They chose to be independent but not isolated. And we're trying to encourage that independence because that's what makes care in our marketplace so amazing. It's those small single guys that are still valuable in that marketplace. So we started with education, and I was interested to hear about the Data Palooza because we actually hosted our EHR Palooza just a few weeks ago for our physicians. we've had vendor click-offs. We have all kinds of events where we were educating our physicians about the incentives, about the value of EMRs, about the value of technology, and what to look at to make the right decisions. Because in 2 years, I don't want to be helping them figure out how to get their data out of the EMR vendors that went bankrupt. I want to be sitting at the table talking about what it is next we can do with the care. And we're baselining all the metrics as our you know, I don't know how many of you know about the CITEL report, but there's somebody up here that was involved in it about the value of information exchange and the savings that you really can get, which is a multiplier of what's available by the incentives. And there haven't been a lot of studies since. And yet those numbers, and I've worked it out with the more than 600 physicians we've helped adopt EMRs over the past few years, and the numbers aren't that far off. And so the reality is we've baselined everything in the physician offices and in the hospital to demonstrate as we go through this process. And so we are deploying our information exchange and the EMR adoption as one initial project with staging. So we helped physicians a year and a half ago adopt EMR, e-prescribing, those docs that didn't have technology, and they've since qualified for $1.2 million in federal incentives. And if you put $1.2 million in the hands, in the pockets of private physicians, they're very friendly and very engaged with us and very trusting. They didn't believe it, and they love to come in every day and show me a check that they got before they cashed it. And I want to say, you know, I didn't believe you. I didn't think it was really possible, but you're right, we did. And these are all physicians that were not using technology at the time that just did e-prescribing, which people say, why would you ever go that route? But let me just tell you that it was a way to get them a baby step into the value of the technology, because now they start saying, well, why can't I do this? And why can't I do this? And why can't I said, that's what an EMR does. And so then we started pushing results out. We brought up our information exchange. We started to push results out into the physicians that had EMRs. We started to push information out into the physician portal that are using e-prescribing, and we're starting to connect all of those up to create that virtual patient record with harmonized data. And we are approaching this kind of quietly. And yet there's momentum with the physicians in the marketplace, and they're the ones that are really leading this effort. It's not us anymore. They've taken on this tsunami and created a, you know, walk around with my iPad and let me show you what I can do with it, you know, kind of thing to each other. And I get more people knocking on the door going, I want to be part of the pilot. I want to be part of the pilot. And I have more pilot physicians. Pretty soon I'll have everybody live in pilot, because that's what they all want to be. And starting that bidirectional information. And this is more than just a CCD kind of exchange or secure email. We're really pushing both our vendor partners and ourselves to think differently out of the box, and then you get into that disease management. And so we have the physician portal, and we have what we're working with on the EMR vendors of that EMR with a view, saying, you know what? Why have to click into a health information exchange? Why send a CCD query, you know, for something when you can get more information by looking at everything? Why have to pull everything back into your EMR? And let me tell you that for as much of interoperability talk that all the vendors say, when you get right down to it and say, I really want to create a seamless view inside of two applications, they choke. And they go, you really want to do this? You really want, you know, we just wanted to talk about the fact that we're doing it. I'm like, no, you have to show me it does it tomorrow, you know. And so, but they recognize we're not trying to take them out of one application into another. It is like, you know, adopting an EMR or planning to go with technology is like planning a wedding versus a marriage. And everybody's excited about the wedding, and everybody's focused on the wedding. And then as soon as you're married and the night after the honeymoon, everybody goes, oh, shit, this is hard work, you know, to stay. And that's really what we've been working through, to say it's not about the wedding, it's about the long-term vision. And so you can't lock physicians into your EMR by holding them hostage or making them bring the data. You marry them, they get to walk out the door the next day and meet other people, and they're still going to come back and love you if you treat them right and you provide them value to being there. And so that's what we're trying to do in getting them all to look at this technology and information exchange a little differently. And because then you get that feeling of sharing, it happens naturally. We're not forcing anything, and yet it's happening faster than we ever thought it would, because that's always an independent mind says, why do I want to share my data? What happens when I'm looking at all this other data? What responsibility do I have for the patient? What's my medical medical liability. I said, you're a physician, you're liable for everything. You know, I mean, at the end of the day, you're supposed to be looking at this information. Our job together is to figure out how to quickly get it in front of your eyes so that you can make decisions with it and make it useful to you, because if all we do is throw a bunch of emails, you know, most of these physicians don't have emails. In the academic environments, yes, but in the community, no. They've not gone through this inundation of how do you handle and manage all your emails. And I personally still have 11,000 emails in my inbox I haven't filed. But I mean, the reality is if I miss an email, nobody dies. And if that's all we do is apply this to physicians, they're going to be in a sorry state in a few months when we turn on the fire hose and they've got all this information flowing at them, but no training in medical school, no training anywhere about how to handle it. And so we've really engaged our physicians to be part of that innovation, to be part of that pilot testing. We've got physicians, you know, they wear glasses with a little video cam while they're using the application, you know, that you use when you go mountain biking. And the idea is they can talk and look at what they're doing without somebody looking over their shoulder trying to capture it. It's real time. We don't do a lot of training to say, how intuitive is this for you to figure out and pick up day one? And try to get that kind of feedback, both from a variety of physicians and office staff and a variety of technical savvy. And it's been the older ones that everybody says can't learn a new trick that have really been the ones that are creative in what they're doing. And so I think some of the keys to success of what we've been doing is that one size doesn't fit all. Is it just because other places have adopted other technologies that doesn't necessarily mean what we're doing is wrong or what they're doing is right or wrong? The idea is there's going to be a lot of innovation going around and a lot of best practices that we want to share and build to help other people go through that process as well. And we are focused on that long-term visibility of quality. And yes, the meaningful use incentives are out there, and you'll hear later our reality with that and physicians in saying what the real value is to a practice in cost savings when you adopt it at the broader level and jumping over what's going on with 1 and 2 and get all the way to 3 and 4 and where we need to be in that. And that we have some amazing vendor partners who have really gone out of their way to do things that they know isn't being required of them today, but it's the right thing to do. And we always say that sometimes the right thing is not always the easy thing, but they recognize that is where it's going, and why not pilot some things in our marketplace with an environment where the physicians truly are engaged. And we have seen real benefits of real-time result delivery, and actually the physicians have led the changes. When they saw how quickly a signed document was available in the community record for the other physicians, they dictated faster, they turned around signing faster, they realized, you know, from 30 days to 4 hours. And we didn't ask them to do that. And now they're driving in throughout the medical committee, throughout the medical staff committees, a requirement to dictate all reports or to create templates within so many hours or minutes, depending on the site, if the ED versus the inpatient side of getting that documentation electronically. They know they can't tell the community physicians anymore, I did do that report and dictate it, it must be lost in the mail. And so the fact is that that visibility and transparency has created a real community around those physicians. And real-time, I want to say engagement in what they, you know, in a few months, that whole issue and questions have gone away because they've shamed each other to say we should be looking at that lab result or we should be capturing that information because that's the right thing to do. And so when we talked about, one of the questions they asked us to say is, what have been your challenges to date? Technology evolves faster than wisdom. And our job is to try to stay out ahead and try to help the physicians and our organization through that use of wisdom. I mean, I always say that technology advice has a shelf life of fruit. And so we have to sit there and be creative and always transforming what we're doing and thinking differently and not let the things that we can't do get in the way of what we can, and just keep moving forward and doing those things and inspiring. You know, you don't see anything about the legislation or vendor, you know, availability or competing requirements that we've got going on or resource issues. You know, that's not what our challenge is. Our challenge is to keep us all going, as you heard from the earlier speakers, keeping that inspiration going and keeping physicians to say that we're not stopping at go live. That is just the beginning in what we're doing. Because at the end of the day, physicians are somewhere between that national treasure and natural resource, and unfortunately becoming an endangered species. If I raise a hand, my father and brother are both radiologists. They both retired this year. that's a sad fate when my baby brother is retiring because he doesn't want to stay in medicine with where things are going. And that is, you know, we're in Pasadena, and yes, it's a beautiful place to go, but we're a 20% higher cost of living and a 30% lower reimbursement rate. So it's hard even for us to recruit and retain the best and the brightest in our community. And so we're saying that as an organization, we have a responsibility as a hospital to help physicians achieve operational improvements and to stay in a practice viability. I always steal the Kaiser line. We're helping physicians not just survive, but thrive in our marketplace. And we want them to focus their energy on why they got into healthcare in the first place. Because if they practice, if I convince every one of the physicians that I've met, practice just one more day, they would have touched, healed, or saved 11,000 lives in that one day. And who knows who is among those 11,000 people that becomes the next Da Vinci or Mozart or President of the United States to help healthcare reform, or just another physician who goes on to treat another 11,000 patients a day to help us in that end effort. So that's our job, to try to make sure that they just want to practice one more day, because at the end of the day, healthcare is not a commodity. It is a community. We are doing it one community at a time, and one physician, one person, one day at a time, because we don't yet know what questions we're going to even ask. But at least we know we've got the technical infrastructure, we've got the data, we've got the engagement of the physicians, to try to figure that out, so that when we wake up tomorrow and we're faced with something new, we know how to address it. Thanks.
Well, good morning. In our preparation call we had with Susan, we were supposed to hit her top three, which is benefits, opportunities, and challenges. And originally we weren't going to use slides, so I must have missed a memo somewhere along the line. So I don't have any slides, but I'll try to connect some of the dots. In Steve Jobs' commencement address to Stanford grads in 2005, he talked about connecting dots is something you do retrospectively. You can't connect it forward. So I'll try to bring some of these stories together, because I fall somewhere in between. If Rebecca talked about herself as a single hospital with lots of physicians, and Kaiser might be more of a commune with all of the integration that it has, we're about 1,000 multi-specialty group practice within a larger health system, Palo Alto Medical Foundation. So benefits, opportunities, and challenges, I'll look at sort of like a past, future, and how do we get there. So the past, the benefits, clearly I've been practicing with an EHR for over 15 years, and it just doesn't, I don't even almost remember what it was like in the old days. But I did a couple studies that helped prove why would you even want to do this. So back before the EHR, when I was at Stanford, looked at, well, what's life like with practicing with paper? And did an ethnography study at the time. And turned out, of the people you see in the office, 81% of the time you didn't have the information you needed to make decisions for that patient that day. Missing about 4 pieces of information just for that day. The question that was being asked is the system really broken? Well, that study sort of said, yeah, really, really routinely broken. The other thing we did, this was at Northwestern then, is looked at, well, what happens if you do insert this, at that time, 15 years ago, new technology? One of the things that helps is clinical decision support. So at that time, this was in a practice, a faculty practice at Northwestern, where half the folks, this is probably unethical now, but half the folks used an EHR and half in the same department didn't. And then we had some blinded reviewers looking at the records retrospectively and said, did these people on the last in the last encounter make the most appropriate decision? Well, the Northwestern faculty practice, on a scale of 0 to 5, 5 appropriate, 0 totally inappropriate, 3 being neutral, scored less than neutral. So we're making less appropriate decisions looking as a Monday morning quarterback. And folks in the same department who did use an EHR were making more appropriate decisions. So this is sort of a looking back, gosh, the way it was, Todd talked about, gosh, you wouldn't even imagine such a thing even 5 years ago. But that's where we're headed. So the benefits are very, very clear. What about the opportunities? It's sort of future looking. I think one of the biggest opportunities is the empowerment and engagement of patients and their families and caregivers. We talk about, and I'll mention it towards the end, about the EHR and the data for us as the healthcare professional, probably the biggest missing gap and the biggest opportunity, a bit like Todd spoke about this morning, is giving this to patients and having them really have a level playing field to fend for themselves. That's been immensely empowering and immensely transformative. So if we look at the resources we have, we only have us. We talked about the more and more limited time we have as healthcare professionals. Gosh, patients have the rest of the 24 hours in that day, and so do their parents. When my dad had a stroke, one of the folks in the practice reminded me, well, stroke, I'm sorry to hear that, stroke happens to a family. And indeed it does. And if we don't empower the entire family, we're missing a huge opportunity. So that's an untapped resource. So I think that is one of the biggest opportunities we haven't talked about as much. One of the things we do, for example, is we had an online disease management program for diabetes. So to take care of the rest of the 99.9% of their lives, because it affects every second of their life, give them the data, give them the tools, give them the knowledge. Again, a little bit like Todd Park was talking about this morning. And finally, in the benefits, opportunities, and challenge, the challenge is you need good implementation of good products. So we sort of have that in the product. We need better products, and we certainly need better implementation. To mine the value of this kind of access to data and access to knowledge at the point of decision making, to make that available to everyone, as I say, including the patient and family member of this health team. And it's not just health care, it's the whole health and health care. And the other piece is the implementation. So if we don't do a good job at both of those things, good implementation of good products, in addition to not mining the value, we do sustain some of the risks. The IOM is going to release a report later on this week, actually on Thursday, about the possible risks of use of HIT. So we have to be mindful of both of the benefits and the risk. And as Todd said, with the great country and the great resources we have amongst us all, I think we'll do a fabulous job. So I want to close in talking about a different kind of innovation, an innovation in policymaking. So high tech, it's pretty a strange story. High tech was built, was put into this stimulus bill as a result of this banking scandal, but it was enormously enabling. So it gave us $30 billion, which is 3 orders of magnitude more than we had before. So we were trickling along, spending investing about $50 million a year. And now all of a sudden we have $30 billion over the next decade of incentive money. And I think that's changed the landscape. I really think it's a good thing it happened a year before health reform or the ACA bill, but it really is the enabler. It's the enabling platform not only for better care, better health, but for innovation. One of the ways that I think it's innovative is it had this phrase, meaningful use. I chair the Meaningful Use Work Group of the HIT Policy Committee, and what we said about in terms of the category, how do you qualify for this money? It was not a cash for clunkers. It was not a cash for software program. It was cash for doing something to improve health and health care. And the way we structured it, our advice to CMS and ONC, to HHS in a sense, this is the FACA, Federal Advisory Committee, is to categorize these objectives or criteria into 5 categories. 4 of them clinical, 1 of them foundational. The first one people would have guessed. How do you improve the safety, quality, and efficiency of healthcare? What we tagged onto that category was, and reduce the disparities. So we all talk about disparities, but we actually don't capture the data to measure it unless you do it in a specific research study, for example. But the HRs are now going to capture that information routinely. That is, if the providers want their incentive money. The second, as I said, was probably the most meaningful for me, and that was to share information with the patient and caregivers. This was originally thought of as a, quote, EHR incentive program. What we tried to do is say, with all that data in electronic form and in computers, we've got to give it to the people who care the most about it, the most vested interest, and that's the patients and their families. So that is actually baked into the criteria for getting your meaningful use incentives. The third and fourth have to do with things that we don't think about, and in fact the products don't give us automatically. We've been asking for it for decades, but it's just not there because people don't get time to do this. One is care coordination, which is to deal with all the stuff that falls through the cracks as you go from one provider to another, or physician group to hospital and back again. How do we keep that information flowing? It's not something that happens naturally. That's why it was an important part of the incentive. And the fourth was the population public health. So we know how important every year, let's say, whether it's H1N1 or swine flu, there's some global impact on healthcare in each one of our communities. How do we make that manifest at the time people are being seen for health and health care? So that's being baked into the EHRs and into the way of thinking and into the liberated data. And the final thing is we can't do any of these functions safely if we're not guarding the privacy and security of that information. So that's just a part and parcel of the whole thing. So in closing, this is really a time to advance innovation. It's a time to get this platform correct, this EHR, PHR, the HIT platform. And it's a marvelously exciting time to be able to improve health and healthcare. So I look forward to your comments and questions. Thanks.
So, Paul, not to worry, you were right. That was exactly what we agreed to talk about. And I want to stay on this theme of the benefits incurred to date by the systems you have put in place and the educational assistance you have given your providers. Let's keep talking about the benefits. Let's keep talking about the opportunities and the real challenges to getting to really making true. I think, Rebecca, on your slide, it was from meaningful use to meaningful value. That obviously is the objective that all of you share. So, Jack, you said one of the benefits, and you showed us that slide, 88% reduction in cardiac-related mortality. Let's drill down a little bit more on that. How do you discern that much was related really to the movement of HIT into the Kaiser Permanente system in the way it has been mobilized, and what has flowed from that specifically? Right.
Well, to be just completely clear, the 88% improvement was not a side-by-side study where we thought they were equal paths. We abandoned the old way, so it was an historical comparison to how it had been done previously. There had been that change. Part of that reflects the clinical reality of how post-myocardial infarction patients were managed for a long time, which was, rest and not get too active and all that. So this was about trying to take the more advanced clinical practices using teams, connectivity with clinical pharmacists, nurse managers, and physicians, and information and tracking through registries to actually go from that older model to the more accepted scientific model, which was harder to deploy and implement in a one doctor in charge environment. So it was new information that was enabled by having the information and the technology to enable the team to interface with the patient to get better compliance. Okay, so essentially it was a part of the platform of moving to this very different way of delivering care. Nothing magical about the technology in terms of its direct impact.
So beyond that, what would you say has been the greatest overall benefit of the adoption of KP Health Connect and the patient portal?
I think that, and I loved Paul's comment about a stroke doesn't happen to a patient, it happens to a family. I think that one of the things that we have learned is that bringing the patient into a more central position in terms of access to the information, sharing of the information, which initially was a little worrisome to us because, we come from that industrial age with the doctor at the center of everything, and we actually found out it was quite liberating in many ways. Number one, patients don't just want websites and don't just want good data and good information. They want a trusting relationship at the center of that. But once you have that, you can enable that and advance that by lots of connectivity. So if you have a trusting relationship with your orthopedic surgeon about something, you don't need to see her every time you have another twinge or something. You can say, this has happened, and exchange by email. One of the most graphic examples that just came to me from a neighbor, I have a house up in the mountains in Colorado, and I had a neighbor come up to me and says, let me tell you my Kaiser story. And sometimes when you hear that, you're not sure what you're going to hear.
You want to dig a hole in the ground.
You're not sure what you're going to hear. He says, you guys have now allowed my wife and I to travel again. And I thought, well, this could be a good story. He said that he was a retired attorney, 60-some years old, has a mother in her middle 80s who's a little frail, and he has proxy access with her internist and her doctors so that the physician, the patient, and her son have complete, open, transparent access to her care. And so he felt like because of that and the fact that, again, he had a trusting relationship with her primary care physician, that they could actually travel. And they went to Europe, and he said, and on day 2, I got an email from my doctor and my mother that she had fallen. They had had to check her into the emergency department. She didn't break anything. She went home. He said, you know, we just went on about our day, and we slept that night, he and his wife, because they felt such a sense of relief. So it really amplifies what Paul said, which is a stroke or whatever doesn't happen to an individual, happens to a family. So if you can imagine of different ways to use not computers, but IT and that community of information to support people, you actually improve access and connectivity.
That's great. Rebecca, share with us your sense of the greatest benefits as the physicians whom you mentioned are dealing with 11,000 patients a day, how they have seen the benefits through their own practices.
Well, I think we've had a couple examples real time. One of the practices that came up that afternoon, on a Friday afternoon, that evening, had one of their patients show up in the ED, family practitioner out in the community. And normally they wouldn't hear about their patient being in the ED until the ED physician had done all of his workup and called out. This is one of our physicians. We have about half of our docs use hospitalists, half of them don't. And they would have gotten a call about 1 in the morning and told, you know, we went through this workup, this is what we're going to do, you know, and this is what we'd like you, your next direction. And she said that her office was closed. She's sitting in the office. She's doing paperwork. She sees an alert come back that her patient's in the ED. She called the ED and talked to the ED physician on duty and said, you know, you don't need to do this, 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 and this. I know what's going on. Here's what you need to do. I'll be over there. This is what you can start. And she said instead of a call 4.5 hours later, you know, in the middle of the night, she was able to take care of it before that and save both the organization, patient time, and money, and end up with a better outcome, and most likely. So, I mean, that's a real example of what you can do when you're providing real information. The other is we have a lot of physicians that adopted EMRs or had purchased EMRs. I won't say adopted, purchased EMRs. But because they were still working in that paper world with everything else, and EMR only works 40% of the activity that's going on in a practice, and the other 60% is happening before they get there and after. And so we've had physicians talk about the fact that they really weren't getting the savings, the complaints, the stories you hear about EMRs just cost us money and time. It's because they didn't fully adopt it and weren't able to engage in all of the value of that information. And so the efforts that we're doing to say it's not about the 4 walls, it is a more global implementation, and it is about that communication between the other providers has really, one, created a more cohesive dream team between the physicians of independence and cut their costs in that effort. And so they really see the value and are talking about the fact you can adopt an EMR without spending tens of thousands of dollars or hundreds of thousands of dollars, and you can get to productivity and even better and beyond within a very short period of time. And so it really isn't about the technology, it's about the implementation and effort, and we've been able to help provide that support because who else do they turn to? The vendors are all busy, very busy, and is that really their role in some cases? Because you can get the best Thermador oven in the world, but the Thermador guy isn't going to teach you how to bake a souffle. And so we're sitting there trying to help the physicians in that effort on how do you use the tools in the best. And so I think that's really been the stories that we continue to hear every day from the physicians in our marketplace.
Paul, you brought up the phrase care coordination, which obviously is a huge imperative for the healthcare system to move farther along that perspective. What benefits, if any, have you seen within Palo Alto Medical Foundation on enhanced care coordination?
That's an excellent question. Now, we do practice in an integrated group practice setting, so there's certainly a shared information amongst the professional healthcare team. What is really interesting about care coordination is to give more of that shared information on the patient side. So one of the things that is available in these PHRs, or the patient portal, is the ability to sign up as a proxy for a patient. So a spouse, or a daughter, or a son, the folks who are related to the patient themselves. That's where we get some of our most wonderful stories of how it has helped them, because we see them such a small, minute fraction of the time of an individual, and the family sees them all the other times. And being involved, and maybe the family member's distant, thousands of miles, but being involved in the health and healthcare of an individual, a senior typically, is amazingly empowering and reassuring at the same time. And so I would say that kind of spread of information. We talk about making sure that everybody on the professional healthcare team has the information. Making sure everybody in the family has the information is just wonderful, because life happens in all those other times.
Like the story Jack brought up.
Exactly right. Mm-hmm. Exactly right. So stroke happens to a family as an example. But also, those are the caregivers, not us professionals. So that's been liberating, it's been empowering, and we probably get some of our most touching stories as a result of that. And it's this technology, not as the main event, but this underlying ability to share information, sharing stories, and getting advice sometimes from the professional side at the time you need it, not during our randomly scheduled visit, or worse, in the crisis at a hospital. So in the fabric of your everyday life, can we provide, and can your family members provide you with the ongoing support for your health?
Well, we know one of the huge challenges ahead of our nation is taking cost out of the current healthcare system. AAA, better health care, lower cost. Some, of course, are saying that what we really need to do is figure out how to get 25 to 30% of the cost out of the system. And we're clearly not going to get there on the existing delivery platform. We have to look at some very, very different ways of providing care. And Jack, of course, this is a key agenda, I know, at Kaiser Permanente. What are the opportunities that exist to continue to take these tools and re-engineer the delivery platform?
How long do I have?
Well, 16 minutes to be exact.
Or a third of that. I think that I'm like Todd Park. I'm just what I'm seeing really does reinforce my enthusiasm and my excitement of what's possible. And I frame it from, if you look at banking, bookstores, airlines, they were in the industrial age not too long ago, where the product, the information, and the power were centralized in the bank. And then they figure out about ATMs, and then they figure out about virtual banking, and they finally moved it. We are moving that, where the power, the information, the knowledge, decision-making go to the patient. And so it is about the information and how you openly share it, and how it allows you to ask different questions. The old model, which was physician-centric, one patient at a time, fee-for-service, is productivity model. How many patients can you see? If you have information, if you have some flexibility around how you manage payment, and if you have good systems, you can ask the question, how many patients' problems can you solve? It's a very different question. You use information differently, you use tools differently, you use teams differently. We had some results on our prevention screening that we didn't like, and the old question was, how do you get people to get their prevention? And the new question is, how do you create systems that optimize the likelihood that patients will get there? So you look at supply-demand and how mammography is used. You then look at how patients come in and miss the opportunities to get prevention. You put some prompts and reminders in the middle of that, and you ask the new question, how do you get your optometrists and your podiatrists to improve mammogram screening? Well, you can't. Well, you do. They come in to have their feet checked or their eyes checked. A prompt goes up at the medical assistant level, and the physician says, or the practitioner says, I agree. You have an open spot, you do that. We did those kind of things using information, monitoring and surveillance, and various types of outreach, moved mammogram screening to tops in the nation. So it's extremely exciting to see how you can leverage information, well-enabled teams, and redesign the delivery system of care. We did not get smarter doctors or smarter pharmacists or smarter nurses when we went from top quartile to #1 in some of those markets. We just learned how to do it better.
And where does the cost piece come in? How do you take costs out? Is it labor savings? I mean, what's going to get 25 or 30% of the cost out of the system?
I don't know what the number is, the bold number. I do know that we need a starting number, which is somewhere 10%. Once we get 10%, maybe we can learn what we've learned, the double loop of learning. I think it's in the overuse, misuse, underuse. It's the categories where things are being done that are not proven efficiencies. I think it's around, honestly, beginning to reward performance and outcomes versus activity and procedures, et cetera. I think it's in all those things. We have lots of segments of care that our current model of care is being done at a lower unit cost than the old model of care. What we need are really disciplined cost accounting, which says where did that difference go, what happened with it. And right now we're a little bit in the milieu of we just spent over $4 billion putting in an electronic health record. Sorry, Judy Faulkner, on day one, that is a utility that's a sunk cost. You then have to use it. But I believe it's around having better information for decisions. I think when patients have better information, they're going to have different views around things like prostate screening, various things. So I think it's about this coalition. It's about Kaiser and Palo Alto and Huntington learning together. How do we create that coalition of learning that says the fabric of the American dream is on the rocks right now, and right in the middle of it is this big anchor called the healthcare cost, and it's hitting corporations, it's hitting families, it's hitting governments. And how do we lead that into a future that doesn't ever compromise on quality and access?
Right.
It is. I believe it is in our hands. I do not believe this is something that is mystically unattainable.
Well, and we all better get at it, otherwise we'll have Occupy Healthcare. Paul, same question to you.
I'm from Oakland.
So, right, you're seeing it in the streets.
I don't know if the boards are up on the windows yet, but they will be.
Paul, same question to you. Opportunities to get costs out of the system, and then we'll come back and ask the same of Rebecca.
Sure. I think Jack's model in the essentially all-in-one roof. It's integrated. It's not around fee for transactions. That's just everybody knows that's a dying and unsuccessful model. And to invest better on outcomes, as the Kaiser model has, it just puts everybody, aligns all of the goals in the right direction. And I think that's also empowered a lot of things that Kaiser's done. We can talk about process improvements like lean, et cetera, but as you point out, Susan, that'll get us so far. It's in the maybe single digits, maybe, but it won't get us to that huge effect. One of the, I'll go back to the patients and caregivers, typically families. One of the untapped resources are those folks, the people with the most vested interest. Some estimates are about $300 billion in terms of what's taken out of our economy by loss of productivity, all the things that when people descend on someone who's ill in the family. And yet we do so little to empower them with the knowledge, data, and tools to help themselves. We need to put them on the front and center, first line team on addressing health, and I think that'll make an enormous difference. We talk about fixing defects, so most of us on the healthcare professional side are fixing defects rather than partnering in a healthy life. And that's, I think, what we have to do. We have to disseminate the things that we know about health, about health care, out to the family. And all of a sudden, actually, we can do that in the 21st century. We couldn't in the 20th and 19th century. We aren't using our tools to do that, though. So the things that we need to do, and Jack talked about this too, in terms of instead of having them come in, and the Kaiser model allows this, let's get the information and knowledge out to where it belongs. That, I think, is going to be transformative and get the kinds of numbers you talked about, like 25% of the cost out of it. And it puts the tools in the people with the most vested interest. And I think it's going to affect more than just health care. It's really the health and happiness of the community and the individual families.
Rebecca, you mentioned you're working with a lot of doctors in ones and twosies practices who are struggling to make ends meet and feeling very good, obviously, about the checks, as you mentioned, from meaningful use, but nonetheless, and you mentioned you have another core that are 5 to 7 years away from retirement, and I bet they're pretty focused on their pensions at this point as much as anything. What do you see as the opportunity to take cost out of the system, and are they conscious of the need to do that? And do they see the technology as enabling them to do that?
Well, you know, most of our physicians are one Medicare check away from not making payroll for their office. And I don't care if that's a 2-doc practice, even up to some of the 10-doc practices are in the same position. There is a true cost of overhead in their practice operations, and we've helped them stay focused as they're deploying EMRs to say, what are the key things you enable first? How do you approach it? How do you really adopt and change your practice so that you are, one, able to reduce your cost, and we've demonstrated that in saying, here's how much less you are spending a month on getting just supplies and effort in your practice, as well as how much time are you spending and how are you collecting more money on a per procedure basis, not because you're coding higher or something, but because you're able to apply resources to either direct patient care or more appropriate care and activity in the practice. And we've demonstrated that and working, and that's part of that baseline and continuous improvement to try to address. So there's true cost in their practice. There's true cost in the hospital we've been able to take out. We're a very devoted Lean Six Sigma organization as well. We baselined everything, and how many phone calls do we get asking for reports, results, things to be resent, refaxed. And all it is a piece of paper when the doctor's sitting there trying to scan something and get to one word or outcome on it. And so we've really been able to justify the investment we made in these technologies and assistance to physicians in our operations because we can truly cut costs. And we have the, I want to say the devotion to actually make the change. Because you can sit there and say you're doing something for a certain reason, but if you don't actually take that cost then out, that person out, and reapply it to where it needs to be if it's appropriate, and if not, you've right-sized the organization. And that's where we're getting to. The other piece of that is we've said this is not just about reducing your everyday costs, but getting to the improving the health in the community. And so by building what we hope is an infrastructure that creates that liquidity of information, fluidity to use it at the decision point, and getting it in the patient's hands. We are frantically trying to get it in the doctor's hands first so that when the patients have it, they've not added an additional burdensome of saying, why, if my lab result is out by 0.1, does that mean I'm, should come in and get a test, and trying to say, let's get it in the hands of the physicians in education fast enough so that when all this freedom of information is coming out, that they're not overwhelmed by those patients calling and asking questions about things that really aren't clinically relevant in that regard. And so we really are saying that that's where we feel the true cost is going to come, that we've reduced the level of BMI in our community, that we've reduced the incidence of diabetes and obesity, that we've gotten information in the patient's hand, because transformation starts at every decision you make along the way, whether you're eating an orange or a donut in the morning. And we want to get it pushed out to there, but you've got to have incremental steps to justify activity, and you can't just get all the way to the end point. And so we are measuring every little piece to say, don't get wowed by the bells and whistles that everything can happen. Make sure you're doing just the basics of reducing that cost and getting information to reduce that activity in the office. So,
I think that speaks to, we focus a little bit from the legislation, et cetera, and our general orientation to our care organizations being accountable. We have to have accountable communities, because health care, depending on the study you read, contributes 10 to 20% to your total health. The rest of it is your environment, your habits, where you live, education levels. There's so many things, and so I think we have to broaden our sense of where the solutions are, and we have to say perhaps hospitals and physicians and organized practices need to be at the center of a community effort, because you see kids who make it through a very tough system and make it, and then they have their friends from childhood who never got out of the system, and we have so much of that in all of our individual communities, and I think that the 10 to 20% that contribute to healthcare is really pushing uphill when you talk about childhood obesity and some of the other things. And we can be very successful in certain of our campaigns. I mean, we used to sell cigarettes in the hospital stores. So
come a long way. We have a few moments left for some questions or observations from people in the audience. So if you do have one, please come to the microphone, either this one or this one over there. And if you would identify yourself by name and affiliation, that would be great as well. And Bridget also has a roving mic to make that a little bit easier if there are questions.
And I would say I was on that call with Paul, and I think we did agree to not
Yeah.
deliver any slides. And then somehow, as my team and I got preparing,
It's just that PowerPoint imperative that everybody feels.
You need
Okay.
a prompt, you just know it.
so we're busted.
Yeah.
Right.
First of all, thanks to all the panel members. Ryan Tarzi from Healthline Networks. Really interested to hear more, Paul, in terms of your vision for patient engagement. It sounds like that's something, a particular passion for you. And when I see some of the things that have been done with the Epic Patient Portal, it's been very exciting when it came out 6 years ago and enabled things like access to your records and lab results and e-prescribing, but I haven't seen as much innovation in terms of the next step. I know that there's some movement, so could you share perhaps, Dr. Cochran, if you could share what you see as the next step for truly engaging the patient and caregiver in a personalized and contextual way?
And let me just also build on that question, if I might. Some of the things you've heard Todd speak about in his presentation, you know, the Asmopolis for using your GPS. Do you see yourselves going into that next generation of technologies to assist in this process of patient engagement? Paul.
So I think it's an excellent question. So we are getting more and more technology to be able to measure. We can measure our steps, our body temperature, our blood pressure, cardiac, et cetera. And what consumers and their loved ones would like to have is a professional help in what do I do with this information. So instead of everybody coming to us, we need to put knowledge out. You know, we've been highly trained in an expensive cost to society. Can we deliver the interpretation of what do you do with this information? What do you do with the number of steps? What do you do with my blood pressure? What do you do with my food intake? Can we do some of that translation and move the decision-making back where it belongs, which is with the individual. They're not all patients, they're individuals, and their supporting system, which are typically their families. And so can we be that support team to individuals, because they have the most vested interest. And I think once we are making this conversion, as we make this conversion, we're seeing so much change amongst what we used to call patients, and I think they're consumers and their support system, which are typically their families.
So what's an example of that? What's going on at the foundation that epitomizes that?
Okay, so a diabetic. Everybody knows diabetes is a ravaging disease. People think of their healthcare provider as the soul of all knowledge and truth. Yet we see them 0.5% of their time or less. Can't we be much more in contact with what's going on, and can't we catch the changes before they become either a visit or a hospitalization? It's sort of, let's be where the issues and the questions are versus being the source of truth and knowledge all the time. Before this technology, you had to come, but we're practicing that same style that was done in the 1900s. You know, people come to doctors. We have the ability not only to measure what's going on in real life, but to be able to instrument it and to be able to provide advice and answer questions in real time. And again, I mean, this model that Kaiser, that's the right model. It's basically, it's a capitated environment where we're contracted to provide services at the time of need, which are not just during, quote, scheduled visits. Now we have the technology to do this. Now we have the connectivity to do this. Now we have the instruments that measure things to do this. We need to let the delivery model catch up with what's possible. And frankly, I think we've got to reform the way we pay for care.
Rebecca?
Well, I can give you a couple examples. We're trying to work right now with, just on the e-prescribing side, of notifying patients what the impact is of not picking up their medication on time, and trying to test something so that we're saying, well, yes, the physician can learn or the staff can learn that the patient didn't pick up their blood pressure med or something, but what does that really mean to the patient? And we're trying to get that education, working with something that we're about ready to do, where it's actually notifying the patient that, yeah, you may not pick up your glucophage or your, or your heart medication or something, but it changes what you get hungry for, it changes what you feel, it changes what you're doing, and so that you may end up in, you know, in the ED or in urgent care and not thinking that that's related at all. Or the mix of medications and what you're feeling and at what time and how you let one go and not the other and what that influence has. So we're trying to work at helping provide that education to the patient so they can make informed decisions and not just leave it that somebody's got to call me or, you know, to remind me, or somebody's got to tell me why I shouldn't take my med. It should provide that education and information. We've got a fairly intelligent marketplace, you know, we've got Caltech there, and yet we still depend or want somebody else to tell us what to do, so that then if something goes wrong, you know, as a patient we can say, well, you didn't call and tell me and remind me of my appointment, or you didn't call and tell me of this. So we're trying to balance some of those things in prompting where we can, which doesn't then take away or add an additional overhead onto the physician side of things.
We're about at the end of our hour here, so Jack, we're going to have to give the last word to you. What's the future? What's Kaiser Permanente 10 years from now as it harnesses all of these technologies? Paint a picture for us of what the level of engagement is of the patients, or the people, let's call them people. Most of us would prefer not to be patients if we could avoid it. The people and the system, what does it look like?
Yeah, we need to remember the role of patient is an involuntary act.
Right.
The role of physician is a voluntary act. It just takes a long time. I think that to sort of what Paul said, I would like to see systems of care developed like ours. I came from 10 years in a fee-for-service practice. I thought Kaiser was a better way to practice it in a group with a prepayment, so I like that. I'd like to see more systems like ours be created out of the accountable care movement and, frankly, compete with us in some of these areas, because I think it'll make us better. I think what we have to do is to continue to say the great observations. It's the patient and their family that are around the issues 24 hours a day. How do we support that and enable that? How do we stay better connected with that? I think the one question that you asked, which is how do we manage the miracles? How do we manage the next device? How do we manage the next brilliant way to interface in these ways? And that's almost a track of surveillance. How do we keep saying, because these are all going to cost money. The miracles cost money, whether they're drugs or whether they're devices to manage blood pressure or diabetes. How do we keep track of the true impact of those and bring them in when we can? And I love the philosophy of what Todd talks about, which is this has got to be an open learning environment. Kaiser's got 16,000 doctors. We don't have the market cornered on things. We've got to understand what are the brilliant ideas coming out of Huntington, what are the brilliant ideas coming out of the VA and Palo Alto. Because frankly, we all should take a higher sense of accountability than our individual market conditions. We've got an American healthcare system and a lot of patients that are just not getting what they need today.
All right. Well, on that note, let me say thanks to all three of you for giving us your very different perspectives on this common set of issues and the importance of these new technology platforms to get us to where we need to go. So join me in thanking this panel for a great discussion. You at this point for tell them what comes next. Thanks so much.
Unfortunately, we're running a little bit behind, so we're going to have to thank our illustrious panel.
Great.
That was just a terrific conversation. Thank you. Thanks. That was really excellent.
Thank you.
Thank you. Thank you.